Good afternoon, everyone. Thank you so much for the Radiology Department for hosting us, of course, and for being part of the neuropathology team led by Professor Salwa, Professor Manal, Professor Dr. Iman, Dr. Riham, Dr. Layla, and Dina. I'm going to present a case 4, which is a courtesy of Professor Dr. Manal Mahdi. So as Dr. Asim presented, we have a 9-year-old girl presented with a right-sided weakness. The radiology has given us a wide range of differential diagnoses based on the location of the lesion, the age of the patient, and the presentation, of course. So let's add to this differential diagnosis using our histopathological morphology. We had received as fragments the tissue pieces as fragments and brain tissue pieces from a left frontoparietal lesion that was infiltrated or replaced by a neoplastic growth formed of cells, sheets of cells which were hyperchromatic and pleomorphic. On a higher power, we can see these cells arranged around certain central lumen or neuropil material. Higher power can highlight what my mentor, Dr. Riham, mentioned, the rosettes morphology. We can appreciate the rosettes here, and they are even multi-layered. So here's our first hint for the case. The multi-layered rosettes are around neuropil material, central lumen, or even we can see two rosettes around blood vessels. So immunohistochemical panel was done to start ruling out our differential diagnosis. CD99 showed a strong membranous positivity. Both EMA here and GFAB was focally positive in the neoplastic cells. OLEG2 was negative. INI was retained, which is a negative result here. And we have LEN28A, which was diffuse strong positive, highlighting our multi-layered rosettes. So we have a case of embryonal tumor with multi-layered rosettes, or ATMR. It's a CNS WHO grade 4. So the previous cases and presentations has widely expressed and discussed the new classification of the WHO CNS5 embryonal tumors, which has a heterogeneous high-grade neoplasms. Pathological, of course, histopathological morphology and molecular stratification is very helpful in determining the type and the intensity of the treatment. We can see that it's the recent classification to medulloblastoma and other CNS embryonal tumors, ATRT, Crinet, ETMR, CNS neuroblastoma FOXR2, BCOR, and CNS embryonal tumor NEC-NOS. So prior to having ETMR as a one classification, it was actually 3 distinct entities, which was embryonal tumor with abundant neuropil and true rosettes, ependymoblastoma, and medulloepithelioma. Now the 3 entities are reclassified as a single entity, which is the ATMR, because they have similar or share morphological, histopathological morphology, which is the multi-layered rosettes. They share common amplification of C19MC, as well as highly specific immunohistochemical staining for LEN28, which we have seen in our case. The age group here, pediatric age group, less than or younger than 4 years, equal predominance for both males and females. Location is highly variable with more common supratentorial, but we can see it as well infratentorial. Here are the 3 entities, which are now a single entity as ATMR, sharing the common amplification as well as the highly specific LEN28, immunohistochemical positivity. Recurrence is frequent as well as the CSF dissemination. And for this specific real life case that we are presenting, this case actually presented again to us and to the radiology department as a recurrence. So that was the case for our ATMR. Putting in mind the differential diagnosis that was discussed by previously by my colleagues and professors, we have ATRT. So unlike our case Etmer, which showed a retained INI, here we have lost INI. Some cases of ATRT actually show focal positivity for LEN28. For CNS neuroblastoma, we still have the rosettes, we still have INI retained, but here OLEG2 is positive as well as synaptophyse. Rest of differential diagnosis, we have ependymoma. Unlike Etmer, LEN28 is negative in ependymoma. We have CNS embryonal tumor, NEC or NOS, and pediatric high-grade glioma, which also, unlike Etmer, it's a LEN28A negative. So the conclusion or the take-home message is we have 3 distinct features which are very helpful to reach a diagnosis here: the morphology under the microscope, which is the multi-layered rosettes, the LEN28A, which is available and used as immunohistochemistry, and the molecular testing, which are major helping tools to reach the diagnosis. Thank you so much.
Next case, Dr. Marwa Mohammed.